I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. We're switching it up a little bit this week at the special request of one of our amazing listeners. Asma has asked us to cover the incredibly relevant topic of syphilis.
Such a good topic. Syphilis is one of my all-time favourite infections in pregnancy. It's got heaps of history and there are so many interesting parts to it. So, to start us off, what is syphilis?
Syphilis is a sexually transmitted infection caused by the bacterial spirochete Treponema pallidum. It's called a spirochete because if you look at it under the microscope, the bacteria looks like tiny little spirals.
So cute. Now, Treponema pallidum is actually the name of an entire species of bacteria, and different subspecies cause different diseases like syphilis, Beagle, or yaws. The actual name of the subspecies that causes syphilis is Treponema pallidum pallidum. Syphilis is the only subspecies that is sexually transmitted, whereas yaws or Beagle are transmitted through direct contact and predominantly from skin lesions.
So, where does syphilis come from?
The origin of syphilis is actually still in debate, but there are two main theories. The first is that syphilis was carried to Europe from the Americas by Christopher Columbus. The second is that syphilis already existed in Europe, but it just wasn't recognised until it was first reported in 1494. Most of the evidence supports the Columbian theory. It's actually thought that syphilis mutated from another treponemal infection in America, leading to an endemic of sexually transmitted syphilis. The first outbreak was reported in Europe in 1494 during a war between France and Italy. This random disease came out of nowhere and infected a large amount of the French troops, causing horrific symptoms like genital sores, painful smelly abscesses, and ulcers all over the body. These abscesses and ulcers eventually eroded the bones, causing disfiguration of the body and face. Because of this, it became associated with a lot of stigma, with those afflicted with the disease being mistreated and often isolated in their suffering. Now, as we've seen with the COVID pandemic, everybody looks for someone else to blame. And so for many years, the disease had a variety of names. Usually, people naming it after an enemy or a country who they thought caused it. The Italians called it the French disease, the French called it the Neapolitan disease, the Russians called it the Polish disease, and the Polish called it the Turkish disease. The name syphilis actually came from a poem titled Syphilis or the French Disease, published in 1530. The poem was about a shepherd named Syphilis who blamed the sun god for a severe drought that killed all his cattle. As punishment for this blasphemy, the sun god struck Syphilis and his people down with a disgusting and new disease that was given its name from the shepherd.
Well, that's what you get for blaming the sun god. See, there's so much interesting history. Syphilis outbreaks have been going on for a few hundred years, and thankfully it's become a little less virulent and lethal than when it was first discovered. We actually didn't have a cure for syphilis until 1947. Before that, people were using all kinds of weird treatments. Mercury was a favourite, but it probably caused a lot more illness and death from mercury poisoning than actually treating syphilis. Then there was Salvarsan, which was a derivative of arsenic used in the early 1900s. Salvarsan was also called 606 because it was the 606th compound tested to try and cure syphilis. At one point, doctors were actually infecting people with malaria to treat syphilis, a treatment known as malaria therapy. The high fevers from the malaria killed the spirochetes, and we had a treatment for malaria. So it was easier to infect someone with malaria and treat that than it was to treat syphilis. After penicillin came out as a treatment for syphilis in 1947, we saw a huge reduction in the prevalence of the disease, and it became almost non-existent by 1970.
Now, syphilis has had quite the comeback over the last few years, and as a result, we've seen significant changes to our guidelines, particularly around when to screen for syphilis. So let's get into what's been happening in Australia and why syphilis is at the top of our minds.
Now, a lot of people think that rising syphilis rates is something that has only been happening over the past few years, but actually this has been an issue for nearly 2 decades. In Australia, rising rates of syphilis were first identified in the early 2000s, with significant outbreaks reported mainly in remote Indigenous communities. Since then, we've seen an incredible rise, with rates more than doubling and in some cases tripling since 2015. This resurgence is not unique to Australia, and the incidence of syphilis is increasing worldwide, including for our friends over in New Zealand. Our most at-risk groups include women of reproductive age, Aboriginal and Torres Strait Islanders, men who have sex with men, and those living in outbreak-declared areas of regional and remote Australia. In response to the rise in syphilis rates, Australian authorities have set up a national strategic approach with three main goals: to reduce the incidence of syphilis overall with a focus on women of reproductive age, to eliminate congenital syphilis, and to control outbreaks among Aboriginal and Torres Strait Islander peoples in Queensland, Northern Territory, Western Australia, and South Australia. Supporting the strategic approach is the National Syphilis Surveillance and Monitoring Plan, which provides quarterly reports on progress against the targets in the strategic approach.
So, if we look at the latest monitoring report, we can see a few alarming statistics. Firstly, in the last 3 months, we've seen an increase in syphilis rates in women of reproductive age residing in major cities. This increase has coincided with the highest number of congenital syphilis cases diagnosed since 1995, and the highest number of syphilis-associated deaths ever reported in a single year. The total number of congenital syphilis cases in 2023 was 20, with 10 of these babies dying. What's also important to note is that 80% of women giving birth to an infant with congenital syphilis were actually diagnosed late in pregnancy.
So, the changes to our antenatal screening guidelines have been largely driven by rising rates of syphilis and the national strategic response to try and reduce the rates of syphilis infections, and in particular, the rates of congenital syphilis. Now, guidelines are still state specific, and we know we have a lot of listeners around Australia and New Zealand. So, we'll try and summarise the guidelines for you as best we can. Keep in mind, though, that we're all from Queensland, so if we get it wrong, please let us know. Historically, screening occurred only at the booking visit, which is still the case in New Zealand. Most Australian states now recommend screening at booking and again at 28 and 36 weeks. This includes Queensland, Western Australia, and Victoria. Women should also be tested at birth if they are at high risk, receive treatment for syphilis during pregnancy, or they miss their 36-week screening. South Australia acknowledges these recommendations but is still evaluating the cost benefit of additional screening in pregnancy. New South Wales screens at booking at 28 weeks with additional testing at 36 weeks and birth for high-risk patients. The Northern Territory and some regions of Western Australia, such as the Kimberley, Pilbara, and the Goldfields, have the most comprehensive protocols, screening at booking, 28 weeks, 36 weeks at birth, and 6 weeks postpartum. Remember, about 50% of women will have no symptoms of syphilis and will only be diagnosed by serological testing. This is why antenatal screening is so important.
Okay, so now that we know how to screen for syphilis, we should probably talk about what we're going to do if we find it. Let's go through a case to help us understand how to manage syphilis.
Okay, great idea. Today we have Kimberley. Kimberley is a 32-year-old woman who presents in her second pregnancy for antenatal care. You've read up on the antenatal screening guidelines, and so you send Kimberley for syphilis screening as part of her routine booking bloods, and also arrange for her to have repeat testing at 28 and 36 weeks. You're now seeing Kimberley at 10 weeks for a review of her booking bloods, and lo and behold, her syphilis serology is positive. What do we do now?
Well, the first thing we need to do is actually confirm the infection. Syphilis testing can actually be quite confusing, so we'll try and simplify it. The first thing to know is what we're actually testing for when we request syphilis serology. When we order syphilis serology for antenatal testing, the lab will first run a highly sensitive screening test that checks for the presence of treponema antibodies. If the antibodies are detected, the lab confirms the result by performing another treponema test. This is typically the TPHA or treponema pallidum hemagglutination assay. If both of these tests are reactive, the diagnosis of syphilis is confirmed. But it doesn't tell you whether the disease is active, inactive, or cured. To determine this, the lab then runs a non-treponemal test. These tests include the RPR, or Rapid Plasmin Reagent Test, or VDRL, Venereal Disease Research Laboratory Test. Unlike treponemal tests, which are reported as reactive or non-reactive, non-treponemal tests are reported as a titer and can be used to monitor disease activity. The most commonly used test in Queensland would be the RPR, although if you really wanted a VDRL test, the lab could probably do it for you.
Is there any other way to diagnose syphilis?
Actually, yes. If your patient presents with what looks like a syphilitic chancre, then you can perform a dry swab and request a syphilis PCR. Syphilis PCR can be performed on serum or tissue samples and detects the DNA of the Treponema pallidum bacteria. This test is particularly useful in diagnosing early primary syphilis when antibodies are not yet detectable. Dark field microscopy can also be performed and involves taking a swab from a moist lesion, like a syphilitic chancre, and examining it under a microscope. In this technique, light is angled to create a dark background, making the specimen appear bright. This allows for the direct visualization of the spirochetes, providing an immediate diagnosis of syphilis. Like the PCR, dark field microscopy can be useful in diagnosing syphilis before the serology is positive. However, it does require specialized training and equipment, and it's no longer widely available.
Okay, so Kimberly's syphilis serology comes back as reactive. The lab automatically performs another treponemal test, the TPHA, to confirm the result, and sure enough, both come back as reactive. The lab then performs the RPR, a non treponemal test, which comes back as a titer, confirming disease activity and current infection. Kimberly is obviously very concerned about this, and she really wants to know how accurate this test is. Is there any possibility that this test could be wrong?
Well, very little in medicine is perfect, and the syphilis tests are no exception. It actually is quite common to get false positive syphilis results in pregnancy, and that can actually occur in up to 30% of women with a positive result. Other causes of false positive results include older age, IV drug use, autoimmune disease, dialysis, febrile illness, recent immunization, or a history of infection with other treponemal infections like Yaz or Beagel. Most commonly, patients with a false positive result will test positive to the syphilis antibody screening test, but negative to either the TPHA or the RPR. This is one of the reasons why we perform 3 tests to confirm a diagnosis of syphilis. It's also important to know that not only are there false positive results, but there can also be false negative results. Treponemal tests can be negative before the chancre develops and up to 2 weeks afterwards. Non-treponemal tests can also be negative when there is an excessive concentration of antibodies in the serum. This is called the prozone phenomenon. And basically what happens with this is that there are so many antibodies that they interfere with the agglutination assay and produce a false negative result. If you were ever wanting to exclude a false negative RPR, you could run the non-treponemal test again, but dilute the serum first.
Far out, syphilis serology is so complex. But basically, screen for antibodies, confirm a positive result with a second treponemal test, like the TPHA, and then confirm disease activity with a non treponemal test, like RPR. All right, so we've confirmed our diagnosis of syphilis. What do we do now?
The next step is to try and work out what stage of syphilis Kimberly has. To do this, you can use a combination of clinical history, examination findings, and past test results. There are 4 stages of syphilis: primary syphilis, secondary syphilis, latent syphilis, and tertiary syphilis. Primary syphilis is characterized by a syphilitic chancre. The chancre is typically a solitary, painless lesion that occurs at the site of an infection. It looks like a raised papule that ulcerates and usually appears 10 to 90 days after the person was exposed. In women, the chancre might appear on the cervix. Because it's so small and painless, the chancre can often go unnoticed, and so many people who have primary syphilis won't be able to recall ever having any symptoms. The chancre lasts about 2 to 6 weeks and tends to go away on its own. Patients with primary syphilis are highly infectious.
Secondary syphilis occurs 6 weeks to 6 months after the appearance of the chancre and is mainly due to spread through the bloodstream. Patients with secondary syphilis typically experience constitutional symptoms like a fever, headache, fatigue, sore throat, myalgia, and generalized lymphadenopathy. They can also experience a rash. The rash starts on the trunk, spreads to the arms and legs, and characteristically involves the palms of the hand and the soles of the feet. It looks like a maculopapular rash that is quite symmetrical, and most importantly, the rash is not itchy. Other manifestations of secondary syphilis include patchy or moth-eaten alopecia, which is essentially hair loss in a patchy distribution on the scalp. Condyloma lata might also occur, which are hypertrophic wart-like plaques that occur around the genital, rectum, and perianal areas. Luea maligna, or malignant syphilis, is a rare but particularly aggressive form of secondary syphilis that is typically found in HIV-positive patients. The skin lesions are usually more severe than typical secondary syphilis and are described as ulcerative, oval, and necrotic, with a central thick crust, usually on the face, limbs, and trunk. Patients with secondary syphilis are also highly infectious.
After secondary syphilis, untreated patients tend to enter the latent stage of syphilis. This stage is defined by a complete lack of symptoms and can be divided into early late or late latent syphilis. Early latent syphilis occurs within 2 years of the primary infection, and late latent syphilis occurs when there's been more than 2 years since the primary infection. Patients with early latent syphilis are highly infectious, whereas those with late latent syphilis are no longer infectious to sexual partners. Importantly, though, late latent syphilis is still able to be transmitted during pregnancy to the fetus.
Tertiary syphilis is a late symptomatic disease that can manifest months, years, or even decades after the initial infection. About 30% of patients with untreated syphilis will eventually develop tertiary disease, although this can take up to 20 to 30 years to become clinically apparent. Tertiary syphilis typically presents as cardiovascular syphilis, neurosyphilis, or gummatous syphilis. Cardiovascular syphilis is the most common clinical manifestation of tertiary syphilis. Symptoms of cardiovascular syphilis do not develop until at least 10 years after the primary infection, and they can come on very slowly and insidiously. Cardiovascular syphilis is usually due to vasculitis and inflammation of the arteries that supply the walls of the aorta. This leads to an ascending aortic aneurysm, calcifications of the ascending arch, aortitis, and aortic valve regurgitation. Coronary arteries can also be affected, resulting in narrowing of the coronary arteries, which can increase the risk of thrombosis and myocardial infarction. Gummatous syphilis is a rare form of tertiary syphilis manifested by gummas. Gummas are large granulomatous nodules with a rubbery texture and necrotic centers that can affect the skin, liver, testes, brain, heart, and bone. They can actually develop in any organ and they can be quite destructive.
Neurosyphilis refers to infection of the central nervous system and can actually occur any time after initial infection. Neurosyphilis is classified as early or late neurosyphilis. Early neurosyphilis typically involves the cerebrospinal fluid, meninges, and vasculature, leading to visual changes, tinnitus, deafness, cranial nerve palsies, and meningitis. Late neurosyphilis typically involves the brain and the spinal cord, causing tabes dorsalis and general paresis. Tabes dorsalis is a disease of the posterior column of the spinal cord, leading to sensory ataxia and lancinating pains. Patients often describe sudden, brief, severe stabs of pain that may affect the limbs, back, or face and can last for minutes or even days. A common finding of tabes dorsalis is the Argyll-Robertson pupil. This is a classical finding often taught to medical students, inappropriately as the prostitute sign, because they accommodate but don't react. Argyll-Robertson pupils are small, do not react to light, and contract normally to accommodation. General paresis is a progressive dementing illness, also referred to as general paralysis of the insane. In the early stage, general paresis is associated with symptoms of forgetfulness and personality change. These deficits often progress to severe dementia. Some patients may also develop psychiatric symptoms like depression, mania, or even psychosis.
So, how do we know so much about the stages of syphilis?
Have you ever heard of the Tuskegee syphilis experiment? Now, this is a really important piece of history that I think everyone in medicine should be made aware of. The Tuskegee syphilis experiment began in 1932 at a time where there was no known cure for syphilis. About 600 African American men in Alabama were enrolled in the project, which aimed to study the full progression of the disease. 400 of these men had syphilis and 200 did not. The study was actually sanctioned and run by the US government, which is the precursor to what we know today as the CDC, or Center for Disease Control. Now, these men had never seen a doctor before and were encouraged to join the study with the promise of free medical care. They were told they were being treated for bad blood. At no point were these men informed of the true purpose of the study, and importantly, they were never asked for consent. Now, here's the real kicker. In 1947, about 15 years into the study, the cure for syphilis was discovered, a single shot of penicillin. The researchers knew about this cure, but they deliberately withheld this treatment from the men in the study. Not only did they not give them the treatment, but they didn't even tell any of the men that they actually had syphilis. Even as these men started to die, go blind, or become insane, not once did the researchers offer effective treatment to the men. In the mid-1960s, a member of the Public Health Service became aware of the study and raised his concerns that the study was unethical. In response, the government formed a committee to review the study, but ultimately opted to continue it with the goal of tracking the participants until all of them had died. This whistleblower then leaked the story to a reporter friend who broke the story in 1972, prompting public outrage and forcing the study to finally shut down. By the time the study shut down, 28 men had died from syphilis, 100 more had died from related complications, 40 spouses had been diagnosed with it, and the disease had been passed on to 19 children at birth. In 1973, Congress held hearings on the Tuskegee experiments, and the study's surviving participants received a $10 million out-of-court settlement. Additionally, new guidelines were issued to protect human subjects in US government-funded research projects. In fact, I think the last man who was involved in the Tuskegee syphilis experiment only died sometime in the last few years. When you hear stories like this, it's no wonder why African American people have a deep distrust of healthcare systems and governments.
Wow, that's horrific. I actually feel a bit sick. I guess that's one of the reasons why we have so many hoops to jump through when we try to get ethics approval for our studies. But I think actually don't feel so bad about that. It makes sense given this is what happens without all of those hoops. Okay, so back to Kimberly. We take a thorough medical history to try and work out what stage of syphilis Kimberly might have. She can't recall ever having a chancre, and although she has had a few viral infections in the past, she can't think of anything that particularly stood out with a rash that might make us think of secondary syphilis. With a relatively asymptomatic history like Kimberly's, this makes it a little bit harder to stage the disease. Next, we would do an examination, checking for any undetected syphilitic chancres, including a speculum examination. And finally, we may need to rely on her previous serology. Fortunately, Kimberly is at a previous pregnancy, and so we can look into her previous antenatal serology to help us stage the disease. Kimberly's last child was born about 2.5 years ago, and so her first trimester antenatal syphilis serology was negative then. So we can deduce that Kimberly must have contracted the syphilis sometime in the last 3 years. Given that she's currently asymptomatic, it means that she's got latent syphilis. And since we can't tell whether she contracted the infection in the last 2 years or not, we need to assume that it's been longer than that and that she has late latent syphilis.
Okay, so Kimberly has late latent syphilis. What should we do now?
Well, now we need to have a discussion with Kimberly. Obviously, the first thing we would do is inform her of the diagnosis and likely stage of syphilis. Syphilis is a notifiable disease, and so once the lab confirms a diagnosis, a copy of the report is sent to the Public Health Authority to help with surveillance and contact tracing. In Queensland, the result gets sent to the Queensland Syphilis Surveillance Service, but each state would have their own surveillance group. We would then need to explain the importance of screening for other STIs and send tests for HIV, chlamydia, gonorrhea, Hep B, and Hep C. Kimberly should be advised that syphilis is a sexually transmitted infection and that contact tracing is extremely important to prevent reinfection and to reduce transmission. Ongoing sexual contacts must be presumptively treated as soon as possible to prevent reinfection during pregnancy.
Contact tracing should be done according to sexual history and clinical stage of infection. For primary syphilis, contact tracing should be done for the duration of symptoms plus 3 months. For secondary syphilis, for the duration of symptoms plus 6 months. For early latent syphilis, for 12 months or from the most recent negative test. And for late latent syphilis, contact tracing should only be for the current partner. If there's any doubt as to whether the patient has early latent or late latent syphilis, contact tracing should be done as for early latent syphilis. So that's for 12 months or from the most recent negative test. All sexual contacts from the last 3 months of patients with primary or secondary syphilis should be presumptively treated with penicillin as a single dose, regardless of their serology result. We should also perform testing of Kimberly's older child, since it's unclear when she contracted the syphilis and whether her existing child may now have late congenital disease.
That's a bit confusing to me about the contact tracing for late latent syphilis. I mean, presumably if the patient had an infection for over 2 years, then she was obviously contagious at some point, right? Wouldn't you want to go back and check on those sexual partners? Anyway, the next thing we need to talk about is why syphilis is important and why we need to treat it in pregnancy. Aside from the obvious risks of worsening disease in the mother, like progression to tertiary syphilis or neurosyphilis, there is also a risk of transmission to the baby. Syphilis infection in pregnancy can increase the risk of several adverse pregnancy outcomes, including congenital infection, pregnancy loss, preterm birth or low birth weight, stillbirth, fetal growth restriction, and neonatal death. The chance of these adverse outcomes can be significantly reduced by maternal treatment during pregnancy.
How likely is vertical transmission to the baby? Are we talking a rate of 100%, or is it possible that some babies won't be affected?
The rate of vertical transmission depends on fetal gestational age, the stage of maternal syphilis, maternal treatment, and the fetal immunological response. Syphilis readily infects the placenta, and transmission to the fetus can occur from the 9th to 10th week of gestation at any stage of maternal disease. Primary and secondary syphilis have a 70% risk of mother to child transmission. Early latent syphilis has a 40% chance of mother to child transmission, and late latent syphilis has a 10% chance of mother to child transmission. The frequency of vertical transmission increases with increasing gestational age. So, if a woman contracts syphilis later in the pregnancy, the baby is much more likely to be infected. Now, these statistics refer to untreated syphilis infection. When syphilis infection is treated, the risk of vertical transmission is significantly reduced to about 1 to 2%.
And what actually happens if the baby becomes infected?
After the placenta is infected, spirochetes enter the fetal circulation, leading to infection of the liver, amniotic fluid, and hematological abnormalities like anemia and thrombocytopenia. Fetal abnormalities are typically caused by an inflammatory response to syphilis, and so you won't usually see signs of infection in the baby before 20 weeks gestation, because before then the fetal immune system hasn't fully developed. Ultrasound findings of syphilis typically appear in this order: hepatomegaly, placentamegaly, anemia based on an elevated MCA Doppler, polyhydramnios, ascites or hydrops, and growth restriction, which can be seen in 15% of cases. With treatment, these findings can usually be reversed, with improvement in ascites, polyhydramnios, and anemia first, followed much later by resolution of placentamegaly. Hepatomegaly can actually take months to resolve.
Is there any role for performing amniocentesis to confirm fetal infection?
Good question. An abnormal ultrasound is not diagnostic of fetal infection, and equally, a normal ultrasound does not exclude fetal infection. And so you can see some logic there as to why you might want to test the amniotic fluid to confirm an infection. The reason why we don't do this is because amniocentesis is not completely without risk, and also it's not really going to change our management. We would still recommend maternal treatment in pregnancy. Treatment reduces the rates of congenital infection, the risk of stillbirth by 82%, the risk of preterm birth or low birth weight by 65%, the risk of neonatal death by 80%, and clinical disease in the infant by 97%.
Okay, so these are the risks of syphilis infection in pregnancy for the baby. What about once the baby is born? What exactly is congenital syphilis?
Congenital syphilis refers to syphilis infection transmitted from the mother to the baby and can be divided into early and late congenital syphilis. Early congenital syphilis is defined by clinical manifestations with onset before the age of 2. Up to 90% of babies with congenital syphilis will be asymptomatic at birth, but those who do have symptoms typically experience hepatomegaly, jaundice, nasal discharge or snuffles, rash, generalized lymphadenopathy, and skeletal abnormalities. Late congenital syphilis is defined by symptoms onset after 2 years of age. These symptoms are due to scarring or persistent inflammation from an early infection, and they're characterized by gumma formation in various tissues. Typical findings include frontal bossing, a saddle nose, interstitial keratitis, sensorineural deafness, which typically develops suddenly at age 8 to 10, Hutchinson teeth, small, widely spaced teeth with notching, mulberry molars, perforation of the hard palate, gummas, sabre shins, which is anterior bowing of the shins, and Clayton joints, which are painless arthritis of the knees. Most manifestations of late congenital syphilis are prevented by treatment of the mother during pregnancy or by treatment of the infant within the first 3 months of life. However, some symptoms like keratitis or the sabre shins might occur or progress anyway despite appropriate treatment.
Wow, that sounds horrendous. Those poor little babies. Okay, so far we confirmed the diagnosis of syphilis, staged the disease as late latent syphilis, discussed the possible impact on Kimberly and her baby, arranged contact tracing, and screened for additional STIs. How do we go about treating syphilis?
Syphilis can be treated with benzathine penicillin. The dose depends on the stage of the disease. Typically, primary, secondary, and early latent syphilis can be treated with a single dose of benzathine penicillin, 2.4 million units. This is typically administered as 1.2 million units as an IM injection in each buttock. How fun! Late latent and tertiary syphilis require 2.4 million units IM injections once weekly for 3 weeks. And patients with neurosyphilis may need larger doses administered intravenously.
Uh-oh. Kimberly is allergic to penicillin. Are there any other medications that we can use?
Unfortunately, no. If Kimberly wasn't pregnant, we would have a couple of different options available. Treatment regimes might include doxycycline or erythromycin, for example. Unfortunately, these antibiotics are only useful at treating the mother. Doxycycline is contraindicated in pregnancy due to its teratogenic side effects on the baby, and erythromycin doesn't cross the placenta, so while mum may be treated, the baby will likely still develop congenital syphilis. Benzathine penicillin is the only medication proven to work in pregnancy.
So, what do we do now? Just not treat Kimberly?
The first thing to do here is explore Kimberly's allergy. About 10% of the population will report an allergy to penicillin, and in 90% of these people, they won't actually have a true allergy. The major symptoms of concern are urticaria, angioedema, or anaphylaxis with airway obstruction, bronchospasm, or hypotension. For patients with these types of severe reactions, you might need to do a course of desensitization and administer the penicillin in the hospital. In these cases, you're best off consulting an allergist for further advice.
Just out of interest, the allergist will typically perform a skin test to confirm an immediate hypersensitivity reaction. Those patients who react negatively can safely be administered penicillin, but should do so in an inpatient setting just to be safe. Patients who have a confirmed hypersensitivity reaction on skin tests can then undergo desensitization. This is usually performed in the hospital under supervision and takes about 4 hours. The allergist exposes the patient to small amounts of penicillin and gradually increases the dose until an effective level is reached, followed by the appropriate therapeutic penicillin regime.
Oh, really? I always thought desensitization took weeks. There you go. So, we've referred Kimberly to an allergist, and lo and behold, her skin test is negative. So, we can give her the penicillin. We arranged to do that as an inpatient though, since the negative predictive value of a skin test is not 100%, and we definitely want to be safe. About 2 hours after her first injection, Kimberly describes feeling really unwell with a headache, chills, fever, and joint pains. What's going on? Is she having an allergic reaction?
So, what Kimberly is experiencing here is a typical Jarisch-Herxheimer reaction. This reaction is an acute, non-allergic reaction to penicillin that occurs in up to 44% of pregnant women receiving their first dose of treatment for syphilis. The reaction is due to rapid killing of the spirochetes, which causes excessive release of endotoxins, lipopolysaccharides, and cytokines, leading to an acute inflammatory response. Symptoms typically occur 1 to 2 hours after the first injection of penicillin and include fevers, headaches, rigors, joint pains, chills, malaise, hypotension, and exacerbation of any existing skin lesions. The reaction is self-limiting and resolves within 24 hours. Treatment during the reaction includes hydration, rest, and paracetamol. In some patients, the Jarisch-Herxheimer reaction may precipitate uterine contractions, preterm labour, and abnormal CTGs in patients in the second half of pregnancy.
Wow, that sounds really scary. Surely some women wouldn't want to have the treatment after hearing about the risk of that reaction.
Well, actually, the risk of adverse outcomes to the pregnancy is likely to be much higher without treatment. So we would always encourage women to receive treatment for their syphilis in pregnancy. It's especially important that we don't delay treatment to avoid the possible symptoms of a Jarisch-Herxheimer reaction, as early treatment is associated with better outcomes. Patients who are more likely to experience this reaction may warrant admission with increased surveillance and include those with HIV co-infection, fetal ultrasound abnormalities, high syphilis titers, or those at viability. In some cases, 12 to 24 hours of CTG might be indicated for patients at viability.
Okay, so we go ahead and administer 3 weekly doses of 2.4 million units of benzathine penicillin. Luckily, Kimberly doesn't have any further reactions. One other point here is that it is really important that the doses are given on time. If the second or third dose is given even 1 day late, then you should consider restarting the entire 3-week course. So, how do we know if our treatment's worked? What kind of follow up does Kimberly need?
Follow-up is typically performed by monitoring RPR titers. This is done at the time of treatment, monthly, and again at the time of delivery. A decline in titer is a good response, and what we are aiming for is a 4 times reduction in titer over 6 months. It's also important that the test is done at the same laboratory for consistency. In patients with a high titer that remains stable, does not reduce by 4 times, or has a rise in titer, you should repeat the treatment, but also check for HIV and neurosyphilis by performing a lumbar puncture to check the CSF. Serial growth ultrasounds should be performed to check for resolution of infection, and what you'll usually see is a resolution of symptoms in the reverse order of which they developed. MCA abnormalities, ascites, and polyhydramnios typically resolve within 1 month, followed by resolution of placentomegaly. Hepatomegaly can be a bit stubborn and may take months to resolve after treatment. Now remember, Kimberly was 10 weeks at diagnosis, and so we are not going to see any changes on the ultrasound before 20 weeks. At least a single ultrasound should be arranged after 20 weeks to evaluate for congenital syphilis, remembering that treatment significantly reduces risk of mother-to-child transmission but doesn't completely eliminate it. On the ultrasound, you should specifically mention the history of syphilis infection and treatment and request an assessment of placental size, amniotic fluid volume, middle cerebral artery Doppler velocity, and liver size and ecrodensity. Remember the association of syphilis with fetal growth restriction, and so you may wish to perform ongoing growth ultrasounds.
All right, so what kind of considerations do we need for birth?
Well, syphilis has no impact on the mode of delivery, and routine intrapartum care is recommended. Obviously, you would want to let the paediatrician know about the baby before he or she is born. The important points to consider are sending the placenta for histopath, doing syphilis serology at birth, and following up after birth.
If syphilis is detected during pregnancy, then the placenta should be sent for histopathological examination, and a dry swab should be collected between the chorion and amnion for PCR. Placentas to women with syphilis often have a very characteristic look, appearing large, thick, and pale. The umbilical cord may be edematous and resemble a barber's pole with spiral stripes of red and light blue discoloration alternating with streaks of chalky white.
Syphilis serology at birth should be performed for all women with syphilis requiring treatment during pregnancy. Other indications for testing at birth include all women if syphilis serology was not performed at 36 weeks gestation, women with a preterm birth with the most recent serology 4 weeks or more before birth, and women who are considered at high risk. High risk women include sexual contact with infectious syphilis case, women or partner identify as Aboriginal or Torres Strait Islander, and they reside in an outbreak declared area, substance use, particularly ice, a woman whose partner is a man who has sex with men, late, limited, or no antenatal care, and a woman who engages in high risk sexual activity. Syphilis serology should be repeated in the woman at 3, 6, and 12 months following birth.
Neonatal serology and IgM should be collected from the baby at birth, not the umbilical cord, and then repeated at 3 and 6 months. An RPR titer greater than 4 times the maternal titer or the presence of IgM indicates congenital syphilis. Neonatal penicillin should be given for 10 days if birth occurs within 30 days of maternal treatment or if there are concerns for treatment failure. A paediatrician should perform a neonatal examination and consider further investigations like a full blood count, LFTs, and a lumbar puncture, long bone x-rays, and a chest x-ray if there are any concern for congenital syphilis. Breastfeeding is fine unless there is an infected lesion present on the woman's breast.
All right, what an episode. So let's summarize some of the key points that we've learned from talking about syphilis. Syphilis is a bacterial infection with the spirochete Treponema pallidum. It is transmitted sexually, but also through vertical transmission and from contact with infectious babies. Syphilis rates are rising, and Australia is currently experiencing our highest incidence of congenital syphilis with a 50% mortality rate. Antenatal screening guidelines for syphilis have been revised to combat this and now typically include screening at booking, 28 weeks, and 36 weeks, with the addition of screening at birth or 6 weeks postpartum for certain states. Screening guidelines are currently state specific, and so your local guidelines should be followed.
There are 4 stages of syphilis. Primary syphilis involves a solitary painless ulcer known as a chancre that occurs 10 to 90 days after the initial infection and spontaneously resolves. Secondary syphilis occurs 6 weeks to 6 months after the primary infection and presents with constitutional symptoms, rash, condyle malata, and moth-eaten alopecia. Latent syphilis is asymptomatic and divided into early latent within 2 years of infection and late latent beyond 2 years of infection. Tertiary syphilis can occur up to 20 years after the initial infection and includes gummatous lesions, cardiovascular syphilis, and neurosyphilis. Neurosyphilis can occur at any stage of syphilis and includes early and late neurosyphilis. Early neurosyphilis involves infection of the CSF and meninges and presents with visual changes and meningitis. Late neurosyphilis involves infection of the brain and spinal cord and presents with general paresis, tabes dorsalis, and Argyll-Robertson pupils.
Testing for syphilis is complex and involves a sequence of tests. An initial treponemal test is performed to screen for antibodies. If this is reactive, the result is confirmed with a second treponemal test, the TPHA. If both treponemal tests are reactive, the lab performs a non-treponemal test, so that's an RPR or a VDRL, to assist with staging and monitoring. Don't forget about the prozone phenomenon, which is where the presence of high quantities of antibodies can interfere with the agglutination assay, resulting in a false negative RPR or VDRL. Other ways to test for syphilis include dark field microscopy of a wound swab or a PCR.
Management of syphilis includes notifying the patient of the condition and impact on her and her baby, informing the patient that syphilis is a notifiable disease and is reported to the QSSS, screening for other STIs such as chlamydia, gonorrhea, HIV, Hep B, Hep C, trichomoniasis, and mycoplasma, and contact screening depending on the stage of infection, which is 3 months plus the duration of symptoms for primary syphilis, 6 months plus duration of symptoms for secondary syphilis, 12 months or from the most recent test for early latent syphilis, and the current partner for late latent syphilis.
The risks of syphilis in pregnancy should also be discussed with the woman. The risk of mother-to-child transmission is 70% with primary and secondary syphilis, 40% with early latent syphilis, and 10% with late latent or tertiary syphilis. The risks of syphilis infection to the pregnancy include miscarriage, fetal death, neonatal death, fetal growth restriction, low birth weight, and congenital infection. Ultrasound findings include hepatomegaly, placentomegaly, polyhydramnios, hydrops, and anemia.
Congenital syphilis refers to syphilis infection passed to the child and can be divided into early and late congenital syphilis. Early congenital syphilis occurs before the age of 2 and involves sniffles, a rash, lymphadenopathy, anemia, and skeletal abnormalities. Late congenital syphilis occurs after the age of 2 and may present with findings like Hutchinson teeth, mulberry molars, sabre shins, a saddle nose, frontal bossing, sensory neural hearing loss, interstitial keratitis, and Clutton joints.
Treatment during pregnancy is only with benzathine penicillin, 2.4 million units intramuscular injection for primary or secondary syphilis, and 2.4 million units IM injection for 3 weeks for late latent or tertiary syphilis. Penicillin is the only treatment that crosses the placenta and treats the baby, and so patients with an anaphylactic reaction to penicillin should consider desensitization. Oh, and don't forget to be aware of the Yarish-Herxheimer reaction.
Follow-up includes serial RPR every 4 weeks to check for a 4 times reduction in titer, indicating treatment success. Serial growth ultrasound should be performed to assess for presence and resolution of fetal abnormalities, remembering that ultrasound signs won't be present until after 20 weeks when the baby's immune system is developed.
Considerations at birth include routine antenatal care, a paediatrician at birth, sending the placenta for histopathology and a PCR, check for thick, large, pale placenta and Barber's pole umbilical cord. Check the maternal and neonatal serology at birth, 3 months, 6 months, and 12 months, and babies should have an IgM tested in addition to serology to check for active infection. Additional fetal testing is considered if congenital syphilis is suspected and may include a full blood count, liver function tests, lumbar puncture, long bone x-rays, and a chest x-ray.
Thanks for listening to this week's episode of The Uterine Sound. If you have any episode requests, shoot us an email at theuterinesound@gmail.com. You can also find us on socials at The Uterine Sound, and don't forget to keep an eye out for our Instagram summary slides later in the week.